Assalamualaikum warahmatullahi wabarakatuh and a very good morning. A warm welcome to all participants from Malaysia, the SEAMEO Network and affiliated countries to IMR-SEAMEO Webinar Series 2024. The theme for webinar today is Oral Cancer in Focus, Bridging the Clinical and Histological Perspective Towards an Integrated Patient Care. I am Dr. Salina from the Stomatology Unit at IMR and I'll be your moderator for today's session. Ladies and gentlemen, before we begin, I'd like to provide a brief overview of the Stomatology Unit and its role within the Institute for Medical Research IMR. The Stomatology Unit specializes in examining tissues from the oral cavity under the microscope to identify abnormalities and diseases. This unit was established on April 3, 1967, and in the beginning, it was known as Division of Oral Pathology and Oral Medicine, and later renamed as Division of Stomatology in 1974. Originally based in Jalan Pahang, Kuala Lumpur, the unit was relocated to its current location at the National Institute of Health in Stia Alam in November 2021. The lab with ISO 15189-2014 certification to date remains the only standalone oral pathology laboratory in the Ministry of Health Malaysia. It boasts the largest collection of specimens related to oral cancer, precancerous lesion, and other diseases affecting the teeth, the jawbone, and oral structures. This unique resource has facilitated our collaboration on research projects with various agencies and universities. This unit also provides consultation and second opinions on microscopic examination of diseases and abnormalities in the mouth and surrounding structures. Furthermore, since the year 2000, the Stomatology Unit has been acknowledged as a training center for postgraduate education in oral pathology and oral medicine specialties. The Stomatology Unit is managed by specialists in oral pathology and oral medicine and supported by technical staff. Now, let me tell you a bit about oral pathology and oral medicine specialty. It is a branch of dental specialty dealing with identification, diagnosis, and management of diseases affecting the oral cavity. Oral pathology primarily involves examining tissue samples under a microscope to identify diseases and abnormalities such as tumors. The oral medicine component focuses on identifying and treating problems in the mouth and nearby areas that don't require surgery, such as chronic pain, recurrent ulcers, or symptoms that present in the mouth linked to other illnesses. For oral pathology and oral medicine specialists in stomatology unit, patients are seen during visiting clinic at Hospital Kuala Lumpur. In other places, oral pathology and oral medicine specialists are based in a hospital that have labs for studying and diagnosing tissue sample. The picture here illustrates the routine procedures performed in our laboratory. It shows the preparation phase before further processing of the specimen. Here is our laboratory in the Institute for Medical Research. Generally, the laboratory procedure involves slicing of the specimen into smaller pieces before going to various procedures in the lab for the preparation of histology slides. The tissue will then be viewed under the microscope to identify the type of diseases. This process will be further described by Dr. Joanne in her presentation later. This slide shows oral medicine team in Hospital Kuala Lumpur. Among the other activities carried out in our unit is annual oral pathology slide seminar, where we bring together pathologists, university lecturers, and Ministry of Defence personnel to discuss complex and unusual cases. Here, a lecturer from a public university is sharing her case. And here are the participants during the seminar. As part of our commitment to raising awareness about oral cancer, early this year, we organised Oral Cancer Awareness Day for the staff at NIH. The event included activities such as talk on oral cancer, surgery, and a forum featuring an oral cancer survivor who shared her personal journey as a patient. This event was done in collaboration with the Selangor and Negeri Sembilan Oral Health Divisions, who assisted us with the exhibition and oral cancer screening. The staff were educated on performing self-mouth examination as a method for early detection of oral cancer. That is all about stomatology unit. Thank you. Before we get started, here are a few housekeeping announcements from the Secretariat. We will not be taking questions during the presentation, but participants may post their question using the link shared in the YouTube channel. The question and answer session will be conducted after both presentations have ended. An attendance link is also provided in the YouTube channel for those who would like to receive an e-certificate of attendance. And lastly, please subscribe to our National Institute of Health Malaysia YouTube channel and link for notification and click for notification whenever there is a new post. Ladies and gentlemen, without further delay, let's begin with the presentation. For today's webinar, we have two speakers. Our first speaker is Dr. Raihan binti Nik Roslan. She is a dental officer in the Stomatology Unit, Institute for Medical Research. She earned her diploma in microbiology from the University of Technology Mara in 2009, followed by a Bachelor of Dental Surgery, which she completed in 2014. Dr. Raihan has various experience among those working in primary dental health care and in oral maxillofacial surgery department, where she has been involved in managing oral cancer cases. Recognizing her interest in oral pathology, she transferred to the stomatology unit in 2023, where she is currently based. Dr. Raihan will be sharing her presentation titled Exploring Clinical Pathological Parameters and Risk Factor of Oral Squamous Cell Carcinoma, a preliminary finding on cases reported by stomatology unit. She will be addressing on the clinical perspective on oral cancer. Dr. Raihan, the screen is yours.
Okay, thank you, Dr. Salina, for the gracious introduction. Okay, Assalamualaikum and good morning to everyone who is currently watching. So the title of my presentation today is Exploring the Clinical Pathological Parameters and Risk Factors of Oral Squamous Cell Carcinoma, a preliminary finding on cases reported by our unit, the stomatology unit. So what is oral cancer? Oral cancer is cancer of the lips and oral cavity. So later in my next slide, I will show you what oral cavity composed of. Okay, so oral cancer ranked number 16 most common cancer worldwide, and it can be found mostly on the surface of the mouth, with nearly 90% being oral squamous cell carcinoma, and the remaining 10% can be malignant salivary gland tumor, lymphoma, sarcoma, and etc. So, according to Global Oral Health Status Report towards universal health coverage for oral health by 2030, the incidence and mortality rates of lip and oral cancer per WHO region, Southeast Asia region ranked the highest. Okay, a little bit on anatomy of oral cavity. So, apart from teeth and lip, we have tongue, floor of the mouth, buccal mucosa, palate, which can be divided into hard and also soft. Okay, next we go to normal oral cavity. So, the first photo is upper gingiva, which mean upper gum. Lower gingiva, lower gum. Labial mucosa is the inner part of the lip, whether upper or lower. Buccal mucosa is the inner part of the cheek, which you can see when you retract your corner of the mouth. And then lateral border, which is the side of your tongue. Dorsum of tongue is the upper part of your tongue. Ventral is the lower part of your tongue. Floor of the mouth. And also palate, which is the roof of your oral cavity. So next, let's go and see how real oral cancer looks like, okay? So for these next photos, I will particularly show you how the real oral squamous cell carcinoma looks like. But before that, I would like to make a disclaimer that the photo of oral squamous cell carcinoma at right side of the tongue. As you can see, the tumor is projecting out, and it has a reddish to slightly yellowish surface with a bumpy to rough surface. Okay, and adjacent to it, it has white patch. Okay, similarly, this is also oral squamous cell carcinoma, but this one is located over the gum. And as you can see, the tumor is actually engulfing or surrounding the lower right back tooth. This is also oral squamous cell carcinoma, but this one is over the palate and it's extending to the inner part of the cheek. Next, this is also oral squamous cell carcinoma, but this one is appear to be ulcer. It is at the side of the tongue also. At the front of the ulcer, you can see swelling, and at the back, there's a white patch. Okay, now I have shown you the normal or healthy oral cavity versus oral cancer. So what is in between? Okay, because oral cancer do not just build up overnight or in a day. Okay, so it takes time. So when you notice an appearance of abnormality inside your mouth, you might want to think that it might be the beginning of oral cancer. However, not all abnormality is pre-cancer. Okay, in my next slide, I will show you some of the abnormalities that are potentially can change into cancer. So this is what we call oral potentially malignant disorder. So by definition, it is a heterogeneous group of clinically defined conditions associated with a variable risk of progression into oral squamous cell carcinoma. Most produce clinically visible lesions. And this one I quote from WHO, latest WHO Blue Book 2022. So actually it means that if you found something that is abnormal inside your mouth and it can be seen with your naked eyes, but it has some risk of transforming into oral cancer, then it could be oral potentially malignant disorder. Okay, so where can this oral potentially malignant disorder be at? It can actually involve any site, okay, but it poses higher risk at lateral border of tongue, okay, the side of your tongue, ventral, which is the lower part of your tongue, and then the floor of the mouth. Okay, as for the epidemiology, about 4.47% of the world's population may have oral potentially malignant disorder. Okay, among them, most cases are reported in the Southeast population. As for the prevalence, it varies among population and is mainly associated with with habits. Okay, and the majority, roughly about 80% of oral cancer cases originate from oral potentially malignant disorder. Okay, let's go to the first oral potentially malignant disorder. The first one is leukopenia. So leukopenia is actually a white patch that cannot be scratched off. You cannot be scraped off. Okay, globally it is the prevalence is about 1 to 4%, but in Southeast Asia, the prevalence can be higher. Okay, next is erythroplakia. Sorry. So erythroplakia is a red patch that possess a higher risk of transforming into oral cancer, and according to study, the transformation rate is about 19.9% to 45%. As for the erythroleukopenia, it is the mixture of leukopenia and also erythroplakia. Okay, next we go to oral lichen planus. So oral lichen planus is actually ongoing inflammation over the surface of the mouth, and it also mostly female will get this compared to male, and the age range usually around 30 to 60 years old. So if you can see from the photos, okay, so the appearance of oral lichen planus, usually it will appear like a white lace, okay, and it can affect any site inside your mouth. However, you can found it more commonly on the inner part of your cheek on both sides. Okay, so patients who have this usually will complain of pain, discomfort, and also burning sensation when they took hot and spicy food. Next is oral lichenoid reaction. So oral lichenoid reaction is the clinical presentation is almost similar to oral lichen planus. However, it is usually secondary to, for example, in picture number 1, due to dental restorative material. So you can see that the lesion is is very localized, just adjacent to the tooth. And then for photo number 2, you can see that the lesion is more generalized. So this one is due to medication or drugs. And in photo number 3, as you can see the lesion, okay, adjacent to the tooth restoration, okay. But when the dentist remove or they change the dental material, the lesion disappeared, okay. So that's how you know that it is a oral lichenoid reaction, because it's a reaction. Okay. Next, we go to oral submucous fibrosis. So oral submucous fibrosis, the main cause is bitter nut chewing. And usually patient, instead of having a pink, healthy, moist oral cavity, they have this pale white color, okay, their mucosa. And then the texture of the tissue become firm and their cheek becomes stiff. The jaw will reduce its movement, and the patient will have limited mouth opening. Okay, it is more common in countries where betel nut is prevalent. For example, in South, in India, Pakistan, Sri Lanka, in Southeast Asia, included Malaysia, Thailand, and Indonesia. But it has the highest prevalence in Papua New Guinea, Bangladesh, and also India. Next, we go to proliferative verrucous leukopenia. So for this one, the etiology, which is the cause, is unknown, but it can be at multiple sites, and usually it is resistant to therapy, but it is usually progressive. Okay, and you can find this most frequently at the gum, followed by your inner cheek, your tongue, and also your palate. Okay, now what are the risk factors of oral squamous cell carcinoma? So it is multifactorial. So it means it has many factors. But today I will only show you the 3 major risk factors. Okay, the first one is betel nut or betel quid. Okay, so I guess maybe my viewer do not understand what is betel quid. So actually betel quid is a mixture of betel leaf, limestone, okay, and also betel nut or betel quid. And this 3 component is called as betel quid. But if you add without tobacco, actually the risk of transforming into oral cancer is 2.5-fold. But if you add betel quid with tobacco, the risk factor is increased to 7.7-fold. Next is smoking habits. So I think apart from cigarette, the conventional one, e-cigarette and also vape is becoming popular. But long-term studies pertaining to e-cigarette and also vape is still are being studied. But in general, you can say that they actually possess some risk of transforming into oral cancer because the vape liquid do contain nicotine, and nicotine we do know that it have a risk of risk to transform into cancer. Okay, vaping liquid often contain nicotine, which is known to contribute to cancer, along with other chemicals that may be harmful. Okay, as for alcohol, even without smoking, okay, high alcohol can induce oral cancer, but if you combine smoking and alcohol, the what they call the risk is the percentage is even higher for you to get cancer. And alcohol also act as an irritant, and it aids or it helps in absorb the harmful chemical that is released from the tobacco into your the cell in your mouth. Okay, now we go to oral cancer data reported by our unit, the stomatology unit. So for oral squamous cell carcinoma, incidence summary by year. As you can see from 2013 until 2023, the trend is increasing, although it reduced slightly during the COVID. For oral squamous cell carcinoma incidence summary by gender, female is more dominating compared to male, but the difference is not that much. Okay. Next is oral squamous cell carcinoma incidence summary by ethnicity. So Malay comes second after Indian, followed by Chinese and others. For age-specific incidence rates of oral squamous cell carcinoma from 2013 until 2023, you can see that the trend is increasing as the patient gets more older. Okay, so it's more dominating in when patient is more than 60 years old. As for the anatomical site incidence rate of oral squamous cell carcinoma 2013 until 2023, the site where we found where the oral squamous cell carcinoma mostly found is over the tongue. Okay, it followed by buccal mucosa, which is the inner part of your cheek, gingiva, your gum, floor of the mouth, maxilla, mandible, palate. Okay, the roof of your oral cavity, lip and labial mucosa. For oral squamous cell carcinoma histological grade, okay, moderately differentiated is higher compared to well differentiated, followed by poorly differentiated, and the remaining is superficially invasive. Okay, now for the risk factors of oral squamous cell carcinoma, mostly it is betel nut based on our data, okay, followed by smoking and then alcohol. So what can we do to prevent oral cancer? Okay, so I would like to quote from this person in 2022. He said that mouth cancer are preventable by identifying at-risk population and by making changes to a risky lifestyle. So here I would like to encourage my friends out there, family members, or all the viewers out there, if you are engaging in high risk habit, okay, please stop before it's too late. Okay, also we need to do mouth self-examination. So even if you do not have any problem, at least once or twice a year, you should go and seek for professional advice. Best to see dentists because they are more familiar with the oral cavity. Okay, this is actually the postcard that we gave to our participant during our oral cancer awareness day in February. Okay, but actually the take-home message that we want to share with you is that if you have swelling, you have sore, you have ulcer, non-healing ulcer that is more than 2 weeks, okay, white patches, red patches, please don't hesitate, go and seek for professional help, okay, because you do not know. Okay. I think if you want to know more about how we do mouth staph examination, you can always go to YouTube or maybe to KKM website. You can find more. Okay. I think that's all for me. Okay. I pass back to our Madam Moderator. Thank you.
Thank you, Dr. Nick Raihan, for the informative talk. For any questions regarding her presentation, kindly use the link available on our YouTube channel to submit your inquiries. We are pleased to welcome Dr. Joanne Goh Pei En as our second speaker today. She is an oral pathologist at the Stomatology unit. Dr. Joanne graduated with Bachelor of Dental Surgery from Penang International Dental College in 2013 and obtained her Master of Clinical Dentistry in Oral Pathology and Oral Medicine from University of Malaya in 2023. She also holds a membership of Faculty of Dental Surgery of the Royal College of Surgeons of Edinburgh. She has delivered several oral and poster presentations and contributed to the publications of articles. Being in Stomatology Unit IMR, reporting oral cancer cases is a routine part of her daily work. It is our great privilege to have Dr. Joanne with us to share her presentation. The title is The Integral Role of Stomatology Unit in Oral Cancer Management. Dr. Joanne will be discussing more on the diagnostic and laboratory aspects of management of oral cancer. Dr. Joanne, we'll hand it over to you now. The screen is yours.
Thank you, Dr. Salina, for the kind introduction. Greetings to everyone and the audiences here. I will be presenting on my second topic, which focuses on the histopathological aspects of oral cancer management. The topic is titled The Integral Role of Stomatology Unit in Oral Cancer Management. You have oral cancer. Imagine hearing these words. For any patient, this marks the beginning of a tough and challenging journey with tests, discussions, and treatments in the fight for survival. The journey of an oral cancer patient involves multiple stages. For example, screening and detection, tumor removal, receiving an oral histopathology report, undergoing additional adjuvant treatment, such as chemotherapy and radiation therapy, as well as rehabilitation, restoration, and monitoring. In that, stomatology unit is often involved in 2 stages, which is the screening as well as the oral histopathology report. Managing oral cancer isn't a job for a single team. It requires a multidisciplinary effort, such as the dentist, the oral maxillofacial surgeons, the oral pathologists, the oncologists, as well as many more, such as the speech therapists. In that, we are involved in first, the oral pathologist is involved in investigations, which means we usually produce the diagnosis of the oral cancer through the oral biopsies. As for the second one, we are often involved in providing the oral histopathology report for the surgeons so that they'll be able to carry out further treatment for the patient. So a bit on our services here. Our unit specializes in providing histopathological diagnostic services involving cases from the oral region. And we cover the areas such as Melaka, Negeri Sembilan, part of Selangor, as well as Wilayah Persekutuan, wherein there isn't any oral pathologist residents there. Next, we are also the main center for receiving oral biopsy and surgical specimen cases. And as Dr. Salina has mentioned, we are the only standalone oral histopathology lab in the whole of Malaysia. So from clinics to lab, whenever a lesion or a tumor has been removed from the patient, this tissue is called as a specimen. And this specimen will be transported, placed into a container filled with formalin, and this is to preserve the tissue. And it will be transported to the laboratory so that it may be processed into a slide, and then it will be viewed under the microscope by the oral pathologist to produce a report. But how does a specimen change into a slide? So first of all, it involves the process called as tissue processing, in which the specimen, as you can see from the first picture, will be cut into small pieces of tissue so that it may be fitted into a cassette. These slices of tissue will then be filled with molten wax, which then form the wax block. From that wax block, it will be sliced into very thin sections of tissue, as what we call as tissue ribbons, so that it can be placed on the slide and further stained with a basic staining, which is hematoxylin for purple, and eosin, which is pink in color, so that it can reveal different tissue components. And as you can see in the last picture, this is an example of how the tissue will look like under the microscope. So this video that I'll show now will illustrate this process further. So here, this is our stomatology unit office. This is located in National Institute of Health. And here's our clinic, visiting clinic, which is Unit Perubatan Mulut and Pathology Mulut, which is located in Hospital Kuala Lumpur. And here is the instrument layout for a biopsy procedure. So first, the biopsy will be identified by the officer, in which they will numb the area with local anesthesia. And once the area is numb, means without pain, they will proceed to cut out the tissue. So just so you know, usually these biopsy procedures are performed by either the oral surgeons, but it can be also performed by other places like dental clinics in other places. And usually they will send it to us. Or if, let's say, in other states that have a pathologist, they will send it to the nearby pathologist. So once the biopsy specimen is taken out, it will be sent to Institut Kesihatan Negara, Stomatology lab. And then it will be brought first to the unit pengurusan specimen, which is shortly known as UPS. So here, the specimen will be registered, and then it will be registered under the Specimen Management Information System, which is shortly known as SMIS. It will have its own barcode as well as its labeling, and everything will be under the system. And once the staff is notified through the system, the staff will go down to the UPS to collect the specimen. And here, the specimen will be dispatched up to the stomatology unit lab, and it will also be recorded into our specimen logbook. And once this is ready, it will be brought to the stomatology unit lab, in which the specimen will be prepared for grossing. So as I mentioned, grossing is the cutting out of the specimen into smaller pieces and to be placed into the slide. So here is our grossing station. With that, our lab technician also will register the patient's demographic data into our integrated laboratory information system. And here shows the grossing procedure, which is usually performed by the dental officer or the pathologist. As you can see, the pathologist is cutting up the specimen, while there are other two people beside him recording how the procedure is done, as well as preparing the cassettes. So once the tissue has been cut into smaller pieces and placed in a cassette, it will be brought into the automated tissue processor for overnight. And here shows a tissue embedding in which the specimen is placed into a molten wax. And then with the cassette placed on top, it will then be hardened to form the wax block. And here is the ready wax block, which is now ready for trimming and sectioning. So with that, it will be forming tissue ribbons, which are thin slices, about 3 to 4 microns thick. And these tissue ribbons will later be placed on the slide. And here's where they put the tissue ribbons into the water bath. And once this is on the slide, it will be stained for hematoxylin and eosin staining. And this is done through the machine as well. So when it's already stained, now we will cover it with a glass cover slip to protect the tissue. And of course, we will label the slides with the patient details as well. The slides are ready and they will be sent to the dental officer or pathologist for reporting. So here is an example of how we usually do it. So we will screen the slides together with other pathologists so that we can come to a diagnosis or even consensus on the cases. It's usually viewed under the multi-viewer, and we'll be have a slide on the wall so that everyone can see it. And once this is done, it will be drafted into the system again, and it will be sent to the dental assistant for after it's been validated by the pathologist, and be uploaded back into the system. So as you can see, viewers, the process of producing a report is quite long, and there is also a time that is usually given for us to do that. So that time, we call it as turnaround time. So turnaround time is actually the time between the specimen received by the laboratory, meaning when we receive the tissue or the specimen, and to the issuing of the pathologist's final report. This turnaround time is usually based on the complexity of the specimen received. 5 days for simple cases, 14 days for usually cases that require additional staining such as immunohistochemistry, or cases that have hard tissue which requires decalcification or demineralization process. A bit on our stomatology unit's work. So here is a graph showing number of specimens as well as number of slides throughout the years 2019 to 2023. As you can see, there is a slight decrease from 2019 to 2021, and that is possibly due to the COVID pandemic. However, our number of slides processed remain consistent, which is about 13,000 above. Besides the H&E staining, which is the hematoxylin and eosin staining, we also do additional stains. For example, special stains to identify microorganisms or any other components such as mucin, as well as immunohistochemistry, which helps to reveal different tissue components such as muscle or nerves. So as you can see, there is a general increase in the utilization of ancillary tests throughout the year 2019 to 2023, which probably indicate a general increase in the demand. Or head and neck region. So hence, I will be discussing more on the reporting that we do on this and how the stomatology unit is important in this part. So what sets the oral cancer patient's treatment journey in motion? It is the histopathology report produced by the oral pathologist. So here is an example of a resected specimen from a patient who chewed bitter nut. As you can see, there is a whitish, rough, fungating tumor seen at the lips area, extending up to the upper jaw, as well as the lower jaw, and also towards the lips. So with the information that we can gather through the microscope, we are able to determine critical details to guide the patient's treatment. As such, this is the core elements for the reporting in terms of the tumor from the oral cavity. And once again, I'd like to remind, this is just for oral squamous cell carcinoma. I will go into detail in the next slides. So the first will be the maximum tumor dimension. Usually when we receive a tumor, we will often measure the dimensions or give the measurement of the tumor. So usually you measure from the front to the back, from up or through the specimen itself. And here you can see the maximum dimension will be from the front to back. Next, we will also do tumor grading, as previously mentioned by my colleague. And this is usually done for the conventional squamous cell carcinoma. So there are 3 gradings. First being well differentiated, second being moderately differentiated, and poorly differentiated. Poorly differentiated, as you see, is often the hardest to diagnose because it might not look like the lining of the mucosa. And also, it might be having very poor prognosis for the patient as well. Other than the conventional squamous cell carcinoma, we have different histological tumor types as well. And it is important to note down what tumor type it is for the current specimen. And this is because they have different prognosis and clinical implications. For example, the first three, as you can see, varicose papillary and carcinoma cuniculatum, are known to have a better prognosis compared to the conventional squamous cell carcinoma. However, for variants such as spindle cell squamous cell carcinoma, basaloid squamous, and as well as adenosquamous, they are known to have a poor prognosis compared to the conventional squamous cell carcinoma. Next, I'll go is into the depth of invasion. So the depth of invasion is important for pathologists as it tells us how deep the tumor has gone into the tissue. So here is a picture of how an exophytic lesion for the DOI is measured. Exophytic meaning that the tumor is growing out from the tissue. Whereas here is an example of how we measure depth of invasion for an endophytic, which is if usually in the naked eye, it appears as an ulcer. So this is important as the depth of invasions will affect the staging of the tumor as well. Next, I'll go into the pattern of invasion, which is another indicator that we find important. And there are usually 5 patterns. But however, we classify them into three mainly two ways: cohesive or either non-cohesive. So as you can see, cohesive is where all the tumor islands remain close to each other, whereas non-cohesive, as well as the last picture, which is non-cohesive but also dispersive, which we call it as pattern 5, they tend to appear far apart from each other. So the worst pattern of invasion would be the pattern 5, as you can see in the last picture. Next, the levovascular invasion and perineal invasion is important because it tells us whether the tumor has spread through the bloodstream, and that means there might be metastasis. So for example, lymphovascular invasion, as you can see in the first picture, there is tumor cells within the blood vessel, whereas the second picture shows a nerve, and encircling it are malignant tumor cells. So that means there is perineural invasion. And this is important because this information is associated with recurrence of the tumor, neck node metastasis, meaning it spreads to the neck area as well, and of course, poorer outcome for the patient. And the next indicator is bone invasion. So sometimes, even despite cancer being a lining kind of mucosa cancer, it can also spread to the bone. And it appears like one is the superficial pattern in which it will affect the superficial part of the bone, whereas infiltrative invasion is when the tumor has gone into the bone marrow tissue. As you can see in the last picture, the tumor has breached into the bone, as this is the bone, and then here is the bone marrow tissue. And as you can see, the pink color, darker pink ones are the tumor cells. Last but definitely not the least, margin status. So margins are the age of the biopsy or the specimen, and they are important because they tell us whether the tumor has been sufficiently removed from the patient or not. So here's an example of a negative margin in which no tumor cells are left in the patient, and here is an example of a positive margin which is bad, meaning that tumors are still left in the patient and has not been adequately removed from the patient. So here's another example of how we measure margin status. We often measure it in millimeters. And this is a picture of the slide. And as well as here is a picture of the microscopic photomicrograph. And you can see there is yellow ink, pink ink on the edge of the biopsy. And this indicates a margin. And here you can see there's pink color things. Those are the tumor cells. And we will measure it from here to the edge of the margin. So as you can see, we will report either whether it's involved, close, or clear. And in this second picture, it is 3 to 4 mm, meaning it is a closed margin. And this margin status is important as it tells us whether the patient would need further treatment such as chemotherapy or radiation. With that, close and involved is not good for the patient. Here's another picture of a resected specimen, and this is a neck dissection. So often, when we cut off the tumor, we will also sometimes remove the neck nodes as well. So here are the listed core elements for the neck. So first, we report the number of nodes per level, and this helps to tell the surgeon or the treating physician on how far the tumor has spread. Other than that, we also report on the positivity of the nodes. Positive nodes meaning nodes having tumor inside, which means there is metastasis towards the lymph nodes. So here is an example of a negative node. As you can see, it's all purple and there is the normal structures of a lymph node. However, in the second picture, it shows a positive node, in which you can see there's a pink colored thing inside the node. And with that, as highlighted by the box, you can see there are tumor islands inside the node, meaning this is a positive node. Other than positive nodes, we also will note that whether there is any extranodal extension. So here is an example of a positive lymph node, meaning a lymph node having tumor, but without any extranodal extension. As you can see here, there is tumor, the pink color one, but it's still, the shape of the lymph node still maintains the same, as in it looks oval. However, in the second and third picture, you can see there is extranodal extension, meaning the tumor has extruded out from the capsule and has gone into the adjacent soft tissue, as you can see here and here. So, as you can see, producing a histopathology report comes with a lot of challenges, as we have to report all of these details. But other than that, one of the reasons that we have the report might take a while is because of the complexity of the oral anatomy. Sometimes the tumor can just not spread to one area, but it can spread to other multiple sites, hence a large biopsy specimen. So what are the best practices of oral management? So as you can see in this picture, these are a few blind man people who are touching over an elephant. So if, let's say, we are, as specialists, we were to work alone, we will be exactly like this picture, in which we will not be able to get the whole picture of the thing, but only parts of, and having different conclusions. So that's why we should manage oral cancer from every angle, meaning all hands should be on deck. So first of all, early detection and diagnosis. Just like spotting a storm before it hits, catching cancer through early regular screenings gives patients the best chance to fight cancer. It's all about staying vigilant and proactive. Second is multidisciplinary collaboration. So imagine a squad of superheroes having different unique powers, so as to the cancer fighting team, such as the oncologists, the surgeons, the radiologists, the pathologists, the speech therapists, and many more. Together, they will form the ultimate team to tackle cancer from every angle. Next will be the personalized treatment plans. So every patient is unique, and so is their treatment plan. So whether it be radiotherapy or chemotherapy or any new therapies, this will be important to help the patient. Also, beyond medicine, we have to think about the patient in terms of her emotional and nutritional needs. So hence, we should provide also holistic supportive care. And last but definitely not the least, continuous research and innovation. So the fight against oral cancer is ever evolving with new breakthroughs and therapies throughout the time. So the most effective way is when the team is always in the forefront of research, ensuring that we have the latest tools as well as the treatments to provide top-notch care. From our part, we have a collaboration between the oral surgeon and the oral pathologist. And for the oral surgeon, usually they will enable correlation of the resected specimens through providing preoperative pictures and radiographs. Other than that, they also give us an appropriate handling and labeling of the specimen. As for the oral pathologist, we provide the essential information through the report so that we will be able to guide the clinicians for their treatment later on. In short, we will need a partnership throughout through constant communication. As a national effort for this collaborative effort between the pathologists as well as the oral surgeons, we have conducted a workshop which helped in the standardization of oral squamous cell carcinoma reporting, and this was done last year. Currently, it is in its pilot phase, and it will be pathology unit in oral cancer management. Second is the importance in standardized histopathological report, as well as the multidisciplinary team effort for integrated management of oral cancer. So future directions would be research on advancing diagnostics as well as treatment strategies. Therefore, we welcome any interdisciplinary collaborations to further this goal. So I'd like to end my presentation by saying a quote from Helen Keller: "Alone we can do so little, together we can do so much." With that, these are my references, and with that, I thank you for your kind attention. So now I'd like to pass the screen back to our Madam Moderator.
Thank you, Dr. Joanne, for delivering such an interesting talk. We will now move on to the question and answer session. Kindly submit your question using the link provided on our YouTube channel. I'll do my best to relay your questions to our distinguished speakers. However, if time constraints prevent us from addressing all questions during this session, our speakers will make every effort to respond to via email. Looks like we're getting several questions from the audience. This question is to Dr. Nick. Does OPMD always associated with pain? The question is from Ridwan from IMR.
Okay. Sorry. Okay, thank you, Ridwan, for your questions. So, does oral potentially malignant disorder always associated with pain? I would say it depends, okay, because some patient might have different pain threshold, but most of the time, the patient usually will feel pain, but I think it's best that if you want to know more about oral potentially malignant disorder and you think that you have oral potentially malignant disorder, you can go to the any nearby clinic, whether government or private clinic, and seek for their expert opinion, because I think prevention is better. And as for I think for the pain, if you feel that the pain is worsening, you should take you can try you can try medications such as the topical gel, which is known as oral aid, or also a Kenalog. If it's not improving after 2 weeks, then please go straight away to the clinic, okay, for better management. I hope I answer your question. Okay, I pass back to Dr. Salina.
Thank you, Dr. Nick Raihan. We have another question. This is for Dr. Joanne from Cairo Faizwan. The question is, I would like to ask either the public can go to government hospital and request for biopsy.
Thank you for the question, Cairo Faizwan. So the public do not usually go straight away to ask for a biopsy. However, we have dental clinics in which they normally will refer the cases to the hospital, because government hospitals usually the department there is the oral maxillofacial surgery, and they are usually receiving cases by referral only. However, if you have a concern in such, you might think that you need a biopsy, kindly go to the dental clinic first, and if they feel there is a need, they will probably refer to the government hospital for further treatment. So I would like to pass the screen back to Dr. Salina if there's anything else to add.
Okay. Thank you, Dr. Joanne. Okay. I have a question for Dr. Nick. This is from Adiba. I get ulcer frequently. What are the chances that I will have cancer in the future?
Okay, thank you, Adiba. So if you have you have ulcer, okay, what you need to do, actually you need to know that not all ulcer will lead to cancer. Okay, so if your ulcer, I mean like if it's small and then it's come and go, not more than 2 weeks, then maybe it's not something that you have to worry. But if the ulcer is persistent, it stay at one location for more than 2 weeks, okay. And then the high risk areas such as the side of the tongue, the floor of the mouth, okay, then you might want to go to the clinic because that area might consider high risk for malignant transformation, but that not necessarily mean you have cancer. Okay, for the again the question is to whether the patient can get cancer
So
in the
in the
future,
future,
right?
if she has
So
ulcer.
yes, so no one actually can guarantee that you will not get cancer, but it's best to regular follow up. Okay, and then if you are engaging with what do you call high
High
risk
risk
habits,
habits.
there are possibility that you will get cancer, but it's not necessarily mean that if you do not have habit, you do
Will
not
get cancer.
you do not have high risk habit, you do not get cancer. Okay, because genetic can also play roles. I think I hope that's answer my your questions. I pass back to Dr. Salina.
Okay. Thank you, Dr. Nick Raihan. We have one question from Dr. Lim. This is for Dr. Joanne. Is HPV testing frequently done for oral cancer reporting?
So in terms of oral cavity cancers, HPV testing is not usually done. This is because there hasn't been any studies to really prove that there is the use of HPV, which is human papilloma virus testing for oral cancers. However, this is a different case for oropharyngeal cancers, which are usually done by the ear, nose, throat surgeons and will be usually sent to the general pet for reporting. The HPV testing, which is actually by using P16 chemohistochemistry, if there is positive in HPV for oropharyngeal carcinomas, this usually brings about a better prognosis compared to those with HPV negative. However, like I said, for oral cancers, squamous cell carcinomas, they do not usually show any significant difference or effect to the prognosis for the patient.
Okay.
So with that, I pass back to Dr. Salina.
Okay. Thank you, Dr. Joanne. I think we'll have one more question. Last question. This is for Dr. Nick. In what way does bitter nut chewing contribute to the risk of oral cancer? This question is from Sangeeta.
Okay, thank you, Sangeeta. So actually, the bitter nut chewing, the bitter nut itself, it contain alkaloid compound. This alkaloid compound, for example, uh, arcoline, archidine, guvacolin, and guvacin. This compound actually can cause DNA damage. Okay, so the DNA of the cell got damaged, and then it's altered the genetic of the patient, and then some more it also promote oxidative stress. So all these factor can actually change the cell into abnormal cells. Also, when this abnormal cell keep on dividing, it will form cancer. I hope that's answer your question, Sangeeta. So I pass back to Dr. Salina.
Okay, thank you, Dr. Nick Raihan. Unfortunately, we have reached the end of our time for question and answer session. Any additional questions will be answered by speakers through email. Ladies and gentlemen, this brings us to the end of today's webinar session. A heartfelt thanks to all participants for your engagement and support. Don't forget to subscribe to our National Institute of Health Malaysia YouTube channel. Before we conclude the session, I would like to announce that we will have the next session of IMR-SEAMEO Webinar series on 27 September 2024. The theme for the next webinar is safeguarding public health, unifying pathogen wastewater surveillance, and antimicrobial resistance under one health approach. Don't miss out. Reserve the date and add it to your calendars. We trust that this webinar has offered valuable perspective on the work we are doing at IMR and would spark interest and could initiate research collaboration with others. You can use the address and contact number given at the end of the session to reach us at Stomatology Unit. We look forward to your participation in our next session. Until then, many thanks from all of us at IMR. Wishing you all the best. Until we meet again, stay safe and do take care.